Good evening, everyone. So we meet again this week, and we will continue our lecture series on Epidermolysis bullosa group of disorders. We have completed the simplex form, we have completed the junctional form, and this week we'll learn about dystrophic form of Epidermolysis bullosa. Now, with the dystrophic form, and as we will go through this video, we'll learn that with the dystrophic form, the symptoms are much severe. They are more severe than the previous subtypes. We have more scarring, we have more dystrophy, we have significant and very morbidity inducing scarring in the patients of dystrophic epidermolysis bullosa, and that is why the name is dystrophic. Okay, because of the intense fibrosis and scarring that usually accompanies this disorder. One characteristic features that I have come across while reading about dystrophic EB is that the mucosal involvement is not that severe. If you remember last week's lecture on junctional EB, you will realize that there the mucosal involvement was significant. Okay, so keeping that in mind, you will realize that as we read more about dystrophic EB, you'll find that the other cutaneous features like scarring, nail loss, scarring alopecia, pseudosyndactyly, all of these features are much more severe in dystrophic type, while the mucosa involvement is surprisingly not that much severe. Another important point to know about dystrophic EB is that it can be inherited as both autosomal dominant and autosomal recessive. So much so that even a single subtype of dystrophic EB can have both kind of inheritances. For example, if you have a subtype of, let's say, localized dystrophic epidermolysis bullosa, localized dystrophic EB can be inherited as autosomal dominant and also as autosomal recessive. Okay, so nearly all subtypes of dystrophic EB have two forms, either the dominant inherited one or the recessive inherited one. Just remember that the dominant inherited one would be less severe and the recessive inherited one, because now you have inherited both the alleles, the recessive inherited one will be much severer as compared to its dominant counterpart. Okay, so what all subtypes I'm discussing, if not individually mentioned, just know that you have both type of inheritances, autosomal dominant and autosomal recessive, and if it is of the recessive type, the symptoms will be much bad, much severe. Okay, so without much further ado, let's start our discussion on dystrophic epidermolysis bullosa. All disorders of dystrophic EB occurs because of mutation in the gene COL7A1. Now, what COL7A1 gene does is it leads to formation of collagen 7. And if there's any mutation in the gene, the collagen 7 will be mutated. Until now, more than 1,000 mutations have been reported in literature, all those different kind of mutations. Now, all of these mutations either can lead to absence of collagen 7 or reduced formation of collagen 7, or the formation is good but the function is not good, so the function is reduced, or assembly is bad, assembly of the collagen. Remember, collagen is a triple helical structure, so you need three strands which come together to form one large strand of collagen. Okay, so assembly could be wrong, or secretion of the collagen could be wrong. So all of these different kind of mutations have been found in COL7A1, and all of them lead to dystrophic EB. Okay, this gene is found on chromosome 3p21, which could be a good quiz question. So chromosome 3, the level of split in the case of dystrophic EB is deeper. It's below sublamina densa at the level of anchoring fibrils. Now, the major constituent of anchoring fibril is collagen 7. I'm writing the Arabic numerals because it's easier to understand, but in exam you have to write it as Roman numerals. Okay, so collagen 7 is an important constituent of anchoring fibrils, and since there is mutation in collagen 7 protein, you have the mutation at the level of anchoring fibrils. So again, revising: basal keratinocytes, hemidesmosomes with keratin filaments, then you have the integrins, then laminins, then you have the anchoring fibrils. here. So the mutation lies at the level of anchoring fibrils, and as we have discussed in the previous 2-3 lectures, that the deeper we go, more is the severity of symptoms, isn't it? More is the scarring as we cross lamina densa. So scarring and milia formation are a good features of this disease. So these are very important features of dystrophic EB. As I've already told you that the inheritance can be both autosomal dominant and autosomal recessive. Okay. One important aspect to know about dystrophic EB, one important aspect for dystrophic EB is that there are increased chances of squamous cell carcinoma especially in the recessive forms of EB. Because of intense scarring and fibrosis, it has been postulated that the chances of getting further damage to the skin leading to development of squamous cell carcinomas in recessive forms of dystrophic EB is substantial. So as I think I have one slide on squamous cell carcinoma. So we'll discuss why squamous cell carcinomas are much important to understand in the setting of dystrophic epidermolysis bullosa. Let's move forward. So this is the same diagram that I have taken from Bolognia, page 540. So here we see the normal keratinocytes, normal basal keratinocytes. We have the keratin filaments 5 and 14. Then we have the hemidesmosomes. Then we have the bullous pemphigoid antigen 2 and integrins. At this level, we will have laminins, and these are the anchoring fibrils. These anchoring fibrils are mutated in the case of dystrophic EB. Okay. So in the DD is dominant dystrophic EB. Okay, so this is dominant. In dominant dystrophic EB, you have the mutation in the collagen 7 or at the level of anchoring fibrils. So the blister cavity occurs below lamina densa. Clear? In the generalized or the severe variant, you will see complete absence of anchoring fibrils. So here you can see the anchoring fibrils are present, but their concentration is reduced. This is in dominant dystrophic. But when you go to recessive dystrophic EB, this one is recessive. And as I've told you, recessive dystrophic EBs are much severe. Okay. So in the dominant one, you have reduced anchoring fibrils, while in the recessive one, you have absent anchoring fibril, leading to complete blister cavity. In the recessive dystrophic EB of the generalized or intermediate variety, you have sparse, small, rudimentary anchoring fibrils. So anchoring fibrils are there in some amount, less amount, but they are not able to function properly. In the recessive dystrophic EB, intermediate variant. Okay. So you have two types of EB, dystrophic EB, dominant dystrophic and recessive dystrophic. In dominant dystrophic, you have reduced anchoring fibrils. In recessive dystrophic, if the anchoring fibrils are completely absent, you have severe variety. If they are present but they are rudimentary, not functioning properly, you have the intermediate variant. Okay, let's move forward. So this is an electron micrograph of dominant dystrophic dominant dystrophic EB or dystrophic EB in general, and you can see that this star is the split cavity or the blister cavity. Okay, and these arrows label the anchoring fibrils. Can you see these thread-like structures coming down here? Now these thread-like structures are anchoring fibril. Here you have the dermis, and here you have the epidermal cell. Okay, so here you can see the lamina densa. This one is lamina densa, and just below lamina densa you have the anchoring fibrils. So it is detached. Okay, so in dominant dystrophic you can see the detachment at the level of anchoring fibrils. If you look at the immunoelectron microscopy or immunofluorescence microscopy, this part is the normal part or the intact skin as a normal control. So you can see a very uniform linear staining of collagen 7. So here the tagged antigen is collagen 7. So what we do is we put antibodies against collagen 7 into the sample, and the sample will get attached, the antigens will get attached to the, of course, collagen 7. And when collagen 7 gets attached and it is normal, it will appear as a normal, linear, uninterrupted, unbroken strand of immunofluorescence like we see in the figure C. In figure B, we see reduced expression. Can you see that it is broken, less lighted? Okay, so reduced expression is seen in dominant dystrophic. dominant dystrophic. Now, reduced expression can also be there in the recessive forms also. As I've said that all subtypes of dystrophic EB can have both inheritances, dominant and recessive. Okay. While the A picture shows recessive form, in recessive form you have complete absence of collagen 7 or normal collagen 7 is completely absent. So you do not see any kind of staining, linear staining, uninterrupted staining. Okay, so that is how and you on electron immunofluorescence or microscopy, you find the levels of anchoring fibrils are reduced in dominant and absent in the recessive forms of EB. Now, these are the some you could say it's an attempt at classification of different subtypes of dominant dystrophic. So, Rooks' latest edition classifies it as autosomal dominant, intermediate, localized, pruriginosa, self-improving, and autosomal recessive, severe, intermediate, inversa, localized, pruriginosa, self-improving. So, you can see that both of the disorders can have both types of inheritance. Pruriginosa can have both types of inheritance. Just remember that the recessive form is always more severe and all the mutations are there in type 7 collagen. Okay, so let's move forward. We'll discuss each and every subtype. So this time is instead of starting with severe, we'll start with intermediate. The reason for that is severe dystrophic EB is very important to understand from theory point of view. So I'm discussing it after I've discussed intermediate and localized. So intermediate dystrophic EB is also known as Pacini subtype. Now this is an older name. You might be asked in some quiz. I don't think so. It will be asked in Viva. So Pacini subtype is intermediate dystrophic. Here the blistering is present at birth, which is severe and widespread. So the whole body is affected. These blisters heal with scarring plaques and milia. Remember, scarring and milia are consistent features of dystrophic EB. They can also be seen in the junctional variant, but remember the severity is very much higher in dystrophic type. Now these blisters, when they heal, you have spontaneous appearance of distinctive scar-like flesh-colored papules on the trunks. Now initially, these were considered as pathognomic of dystrophic EB. That if you see these kind of scar-like flesh-colored papules on the trunk, you're dealing with a child with dystrophic EB. But it has been found that in other subtypes of EB, you can also have these features. So it is no longer considered as as a pathognomic sign of dystrophic EB. Let's move forward. So here you have dystrophic or absent nails. Now the absence of nail is a consistent feature of all subtypes of dystrophic EB. Okay. In fact, you have a distinct subtype of dystrophic EB, which is known as dystrophic EB nail only. Dystrophic EB nail only, in which nails are dystrophic, they are absent, they are scarred, but there is limited skin involvement or no skin involvement. Okay, but dystrophic EB nail only is not a subtype of intermediate. I was just discussing it. Okay. Now, oral involvement is not extensive, as I've already told you, but teeth are involved in the form of enamel defects that may or may not be present. There exists a self-limiting variant, which is now termed as bullous dermolysis of the newborn, in which you have significant blistering at birth, but as the child progresses through age, they tend to spontaneously resolve. Okay. And on immunofluorescence, you see basal epidermal intracytoplasmic accumulations of collagen 7. So what do you mean by that? You have the basal cell of the epidermis, and inside you will have clumping of or accumulation of collagen 7. Now, why is collagen 7, which is supposed to be there which is supposed to be there at the level of sublamina densa, is present in basal keratinocytes? The reason being is that collagen 7 Collagen 7 is secreted by dermal fibroblast and also by basal keratinocytes. So both of these cell types are the secretors of collagen 7. Dermal fibroblasts are the major one, but there is a certain certain secretions of collagen 7. Let's move forward. Now, coming to the localized dystrophic EB, here the blistering starts generalized at birth. So, at birth, the entire body is affected, and as the child progresses through age, it remains localized to the acral sites. So, all the areas like hand, feet, elbows, knees, and legs are involved as the child grows older. So, you have generalized blistering, which becomes localized as the child progresses. So, at the age of, let's say, childhood, you have predominant involvement of acral areas. Scarring is again significant. You have hypertrophic scarring in this disorder. Milia is of course present. Again, I'm telling you, scarring and milia are the consistent features of dystrophic EB. There is significant nail loss with digital scarring. So if you have a nail, very bad diagram of a nail. Yeah, so if you have a nail, you have significant destruction of the nail, and what you see is actually a puckered scar. And this is the dystrophic nail. The destruction could be severe enough to cause atrophic scarring at the ends of the fingers and toes, and that is known as digital scarring. And it's a consistent and an important finding in localized dystrophic EB. A consistent and important finding. So if you see the digital scarring at the ends of fingers and toes, assume that you are dealing with localized dystrophic EB. The oral mucosa and teeth are okay because they are non-acral sites. And the older name for localized autosomal dominant dystrophic EB was known as cocaine-Tourette syndrome. Now, of course, the names are not used, but maybe in vivas or in exams questions, you can answer. And maybe for some extra brownie points, you might mention them in your answer. Okay. But now the names that I've been using for each and every disorder are the names that I've taken from Rooks 10th edition, who has stopped using name terms, and have stopped using terms like generalized, severe, and all that. Now they just term it as inheritance. For example, you have localized autosomal dominant dystrophic EB or localized autosomal recessive dystrophic EB. So this is the term how Rooks is now going to use. So now we will discuss recessive dystrophic EB. So recessive dystrophic EB has variable severity, and it is the most common type of dystrophic EB. Okay, so most common type of dystrophic EB is recessive dystrophic EB. A localized form of recessive dystrophic EB is recessive dystrophic EB mitis. Now, don't get confused with the localized dystrophic EB. Localized dystrophic EB is localized dominant inherited dystrophic EB. As I've told you, all subtypes of dystrophic EB can have autosomal dominant and autosomal recessive inheritance. If it is autosomal dominant, let's say you have localized EB. Localized EB dominantly inherited is localized dominant dystrophic EB. Localized EB recessively inherited is known as recessive dystrophic EB mitis. So don't get confused into this. It's the recessive form which is known as mitis. Scarring and milia again present. Mucosal involvement is mild. Now we will discuss the severe recessive dystrophic EB, which is the most important subtype of dystrophic EB, most destructive, most morbidity inducing, most mortality inducing is severe recessive dystrophic EB. Initially, this was known as Halipo-Siemens disease or Halipo-Siemens syndrome. There is generalized blistering at birth. So at birth, there is blistering involving the whole body, leading to denudation. Denudation means that the skin peels off, the skin just gets removed. Okay, easily. It can easily be taken out from the body. If there is congenital absence of skin, which was initially known as Barth syndrome, but now people have realized that it is just another subtype of or another form of severe recessive dystrophic EB. So in Barth syndrome, you used to see involvement of one side of the leg or arm or any other localized side in which the skin was not there. So congenital absence of skin was known as Barth syndrome, but now they have recognized that it could be a part of severe recessive dystrophic EB. There are multiple cycles of healing and blistering during infancy, and this healing and then blistering, healing, blistering, healing, blistering leads to extensive and progressive scarring of the skin. So this is an important point. Extensive and progressive scarring. There's also pseudosymplectically leading to mitten deformities. So if you have a hand here and there is significant scarring, so much so scarring that the fingers join together to form a mitten. A mitten is like the oven glove that you use to take out things from a hot oven. So this becomes mitten-like deformity. These are known as mitten deformity because of excessive skin, hand, and limb contractures. Okay, let's move forward. Milia is a constant feature. Okay, milia is a constant feature of severe recessive dystrophic EB. There is significant involvement of the esophagus with erosions and scarring. Perioral stenosis can be there, leading to feeding difficulty. You're not able to open the mouth and give food to the child because the mouth, there is stenosis or reduction in opening of the mouth because of extensive scarring around the mouth. The esophagus can also have erosion and scarring similarly. So much so that by the age of 20, 30 years of age, if the child succeeds in surviving till that age, nearly all are affected by esophageal scarring and perioral stenosis and involvement of the esophagus and GI tract. Eye shows corneal erosions, opacities, and scarring leading to symblepharon. Symblepharon means you have eye here, the eyelids get adhered to, they get stuck to each other because of extensive scarring leading to symblepharon. Okay, so there's extensive scarring and the person is not able to open the eyelids even. There is associated refractory anemia, osteopenia, osteoporosis have been reported in association with severe recessive dystrophic EB. Now, no significant periorificial involvement apart from the mouth and the anal area involved. Scalp is commonly involved, leading to scarring alopecia. Now, scarring alopecia is a very important feature of severe recessive dystrophic EB. You can see scarring in all areas, but scalp being a thick skin somewhat escapes much severity. But in the case of severe recessive dystrophic EB, there is so much scarring that even scalp is involved, leading to scarring alopecia, and that makes scarring alopecia a very important feature in severe recessive dystrophic EB. Teeth shows excessive enamel pitting and extensive caries. The lingual papillae are lost, that means papillae on the tongue are lost, leading to smooth tongue. The tongue is very glossy, smooth, doesn't have that undulations of the papilla. Laryngeal stenosis can occur, so much so that tracheostomy might be required for the child to breathe. So you might have to cut through the trachea in order to allow the child to be able to breathe, because the laryngeal stenosis can constrict the laryngeal opening. Pruritus, malnutrition, growth retardation, multiple wounds leading to sepsis. Now these are all complications of severe recessive dystrophic EB. As I said, severe recessive, the most morbidity mortality inducing form of recessive EB, recessive dystrophic EB. The perianal painful erosions are present with scarring, stenosis, and constipation. So similarly, because of perioral stenosis, the child is not able to eat, and because of painful perianal erosions and scarring and stenosis, the child would be constipated. So we have to look at that. Okay, there have been instances of describing a very thin tube of stool coming out from the anus because the anal opening is stenosed. So severe recessive dystrophic EB are associated with a lot of squamous cell carcinoma. About 50 to 80% will develop some kind of carcinomas, and most common of them are SCCs. Usually they occur on limbs and non-healing areas. The things that separates SCC of EB than normal SCC is that squamous cell carcinomas in the severe recessive dystrophic EB are very invasive and they metastasize early. So they are invasive, they are aggressive, they easily spread to the other areas of the body. They are very aggressive. So these two pointers are different from normal SCC that normally develops in the scenario. Treatment includes surgery, chemotherapy, radiotherapy, immunotherapy. Immunotherapy is done by PD1 immunotherapy. There's also reports of use of pembrolizumab, individual case reports, anti-EGFR therapy. So these are all therapies which have been used to treat squamous cell carcinomas occurring in a setting of severe recessive dystrophic EB. If you want to know more about it, this article is good. I will, if you want the full article, just let me know. Maybe I'll mail it to somebody or share in the group. The mortality is excessively high. Within 5 years of developing malignancy, the mortality is very, very high. Mean survival ranges from 1.85 to 9 years, depending on the amount of surgical resection done, radiotherapy used, chemotherapy used, because at times the SCCs are so much aggressive, so much invasive that one modality is not enough. You have to use multiple modalities in succession or together to tackle the case of SCC in a setting of severe recessive dystrophic EB, and that is why the mean survival rate varies from 1.85 years to 9 years. Okay, let's move forward. Inversa recessive dystrophic EB or inverse recessive dystrophic EB. In inverse form, the primary areas of blistering and scarring occur on groins, axilla, neck, and the lower back area. Okay, so it's inverse. So mostly we have seen that in epidermolysis bullosa dystrophic form, you have the involvement of the acral areas, isn't it? More trauma-prone sites. But in the inverse form, you have involvement of the central area of the body, like groins, axilla, neck, and lower back area. It starts as generalized blistering and involvement, generalized blistering and scarring, but as the child progresses through age, it becomes more and more localized to the central part of the body. There are traumatic corneal erosions and esophageal lesions. They are very much common in this form. Nail dystrophy is present, mucous membrane involvement is present, teeth changes are present. The inversa form is also associated with a lot of SCC formation, so we need to keep that in mind. And the theory why the inverse areas or the groin or axilla are affected, because it, like the inversa form of junctional EB, it has been postulated that the collagen 7 can have different forms of stability depending on the temperature. So in the groin area, in the axillary region, the temperature is high. So here the stability is not that good for collagen, and that is why mutated collagen can easily get detached and you have blistering on these areas. Okay, let's move forward. Combined dominant recessive combined dominant recessive dystrophic EB. In the combined form, you have both types of inheritance. Remember, I've told you that each and every subform of dystrophic EB can be inherited as dominant and recessive, but in the combined form, both types of inheritance are seen. Now, what exactly happens is, let's say you have a mother. No, let's say we, in a hypothetical experiment, we have a mother who is a carrier, okay, who is a let's say who has a recessive mutation in one of the gene, or okay, marries a father who has a carrier mutation in one of the gene. You don't have to get into that. This is just for understanding. And if they have a child, the child will have one allele which is recessively mutated, and one allele which will be dominantly mutated, dominant coming from the father and recessive coming from the mother. And because of that, you have the combined inheritance, combined dominant and recessive form of dystrophic EB. So you have co-inheritance of dominant and recessive mutation in the collagen 7 from individual parent. The phenotypical features are more like the severe end of recessive dystrophic EB spectrum. So the features are essentially same as recessive dystrophic EB. Now see, every allele have two parts, two alleles are there, isn't it? In the recessive dystrophic EB, both of them are bad. In combined form, one is bad, okay, sorry, one is bad and the other one is just half bad, dominantly bad. But in the end, both of them are not working correctly. So that is why phenotypically the child will behave like a severe recessive dystrophic EB. So the features are same or similar to recessive severe epidermolysis bullosa of the dystrophic type. Okay, let's move forward. EB pruriginosa. Now, this is one disorder that we have usually we come across during our discussions or during our OPD visits. It is mostly seen in adolescent. There is intense pruritus with prurigo-like lesions. Now, you have to remember that prurigo-like lesions because there is a variant of dystrophic EB known as dystrophic EB pretibial variant. Okay, and in pretibial variant, you have bullous lesions, scarring, which is of the hypertrophy type or normal scarring or atrophic scarring or the hypertrophy scarring at the level of tibias. So EB pruriginosa is an important DD of pretibial variant of dystrophic EB. Shins are most commonly involved. DDs include hypertrophic LP, prurigo nodularis, dermatitis artifacta. Just remember that in pretibial version you have scarring, while in pruriginosa, as the name suggests, you have prurigo-like large nodules. The nodules are very, very large. Treatment is using suprapotent corticosteroids, and the use of thalidomide was found to be extensively useful in EB pruriginosa. So if you come across especially a male child, do consider thalidomide. Self-improving dystrophic EB. This is another subtype of dystrophic EB. Do not worry about how to remember the subtypes. I will give you again a mnemonic to understand. Okay. So in self-improving dystrophic EB, you have neonatal blistering. So there's blistering in the neonatal period. And as the child progresses, there's spontaneous clinical improvement. So let's say in the localized or the acral variant or the intermediate variant, you have generalized blistering, and with age, the blisters get localized on the acral sides. Okay. But in the self-improving dystrophic EB, it starts at generalized blistering, and with age, all the blisters show clinical improvement. So it starts in the first few weeks or months of life with blistering, which gradually improves. The reason given is that type 4 collagen gradually increases. So there's improved incorporation of collagen fibers in anchoring fibrils. Sorry, type 7. So type 7 collagen gradually increases with time, increasing with age, and now it is able to perform its normal function. Ultrastructural signs, that means on electron microscopy, you see dilated perinuclear vacuoles with a granular appearance, which are known as stellate bodies. This could be a good quiz question. Stellate bodies are seen in ultrastructurally or electron microscopy of self-improving dystrophic EB. A subtype of self-improving dystrophic EB was initially known as transient bullous dermolysis of the newborn, but with time the transient word was cancelled out, and now it is known as self-improving dystrophic EB as a variant of self-improving dystrophic EB. A child with self-improving dystrophic EB will have permanent stigmata. Now, what is stigmata? Stigmata are signs of disease, signs of prior disease. So scar is a form of stigmata, a mark on the body which shows that you might have suffered from a certain disease. So there is permanent stigmata present in the case of self-improving dystrophic EB because the lesions have healed with scarring. So just to recapitulate the molecular basis of pathogenesis, you have the abnormalities of anchoring fibrils. The anchoring fibrils are mutated. If it is dominantly inherited, then the features are subtle. The collagen 7 may not be able to polymerize into anchoring fibrils, or there's impaired secretion of collagen leading to clumping of collagen in the keratinocytes, or there will be impaired assembly. So because of any of these features, because of a dominant mutation, you have a subtle or a bit less severe form of dystrophic EB. If the collagen 7 are completely absent, you have severe recessive, and that absence is because of premature termination of codons when the protein is being formed from the genes. Okay. Now, Rooks' 10th edition mentioned glycine mutations as a cause. That means that different types of glycines get mutated, leading to different kind of mutations or frame shift mutations. But I've just mentioned it here. You don't have to remember it. Do not consider that only glycine is involved. Many amino acids are involved. But because Rooks mentions it separately, I decided to include it. Now, coming to the mnemonic to learn about different dystrophic EB subtypes. The mnemonic is picks and clips. Okay, PICS and CLIPS, picks and clips. Okay, let's learn what do we have here. So P stands for the Pruriginosa type, EB pruriginosa. Okay, tibial involvement, prurigo-like lesions, itchy, give thalidomide. I is the intermediate one, which we have learned collagen 7 mutation, initially blistering, but then the level of blistering and intensity decreases with age. Combined, which is inherited both as autosomal dominant and autosomal recessive, but is mimicking severe recessive dystrophic EB. S is severe, which we know about as severe recessive, the most important form. The anchoring fibrils are absent. Okay. N is nails only. This is a variant of recessive dystrophic EB. Okay, we don't have dominant nails only EB. It's a variant of recessive dystrophic EB, nails only. C is centripetalis. This is also a feature of recessive dystrophic EB, in which the scarring, blistering, everything starts from the and progresses in a centripetal fashion. Okay. L is localized. I is inversa, with groin and axilla involved. P is pretibial, which is similar to pruriginosa, but we have discussed the differences. And S is self-improving dystrophic EB. Now, the underlying ones are the major ones, severe, intermediate, and localized. But with this mnemonic, picks and clips, you can easily remember all the subtypes of dystrophic EB. Now, with that, we finish the lecture. For further reading, you can read the individual chapters, but in this video, I've condensed all the 3 chapters, and everything you will learn from this. You can easily learn from this 45-minute video. Now, this article by Shinkuma S, titled Dystrophic Epidermolysis Bullosa Review, is a very good article. If you have time, just go through it, and you will be able to know about pathomechanisms and future therapies of dystrophic EB. I have continued to keep the EB matrix one because in EB matrix, if you download, you can put some random features and you can find out what all features are mostly seen in recessive, mostly seen in dominant, mostly seen in junctional, mostly seen in dystrophic. So you can do that. So I've kept this again as further reading, and EB matrix is a very good tool. So you can further understand how different features are seen in different disorders. With that, we finished the lecture. We have covered the clinical aspects of simplex, junctional, and dystrophic type. Next week, we'll have a discussion on treatment of not treatment, but management of epidermolysis bullosa. Because the management lies somewhat similar for all 3 different groups. Wound care, we'll discuss in brief wound care, gene therapy, mosaic transmission therapy, all sorts of different therapies. In brief, we'll discuss, so that if you go through that video, you can easily write answers on that. I have discussed the 3 groups separately because we need to develop an understanding. What do we mean by simplex? What do we mean by junctional? What do we mean by dystrophic? And that is why they are discussed separately. But now you would have understood that as we go deeper into the basement membrane zone, more is the level of severity and more is the level of morbidity. Clear? Comment any doubts or suggestions in the comment section. I do reply to them. I might take a bit time, but it is replied within a week easily before the next video comes. You can email me, but it's better to write in the comment section because emails do get lost in the amount of emails I get. So without much further ado, adios and bye-bye. I'll see you next week with management of epidermolysis bullosa. Have a great weekend. I think weekend is over. Have a great week. Bye.